Today we're going to have presentations on children's health. And so the first person up is Heather Brahm. Heather, welcome to committee.
Thank you, Mr. Chair. Good afternoon. I'm Heather Brahm, Senior Policy Advisor with Kansas Action for Children, where I work on health policy for the organization. Kansas Action for Children, or KAC, is a nonprofit, nonpartisan advocacy organization based here in Topeka, working to make Kansas a place where every child has the opportunity to grow up healthy and thrive. We have been around for nearly 50 years, working with lawmakers and organizations on multiple issues that impact kids and families, including budget, economic security, education, health, and taxes. Helps if I get my slides advanced. The speakers you'll be hearing from this afternoon work for organizations that advocate for the health of children, especially our youngest Kansans. They research and advise on some of the best policy solutions proven to improve the health of kids, and they treat and help families navigate the healthcare system. To start off this afternoon's presentations, I'm going to provide a quick tour of some of the factors that influence kids' health, as well as a few policy suggestions that you could address in 2025 and beyond. So let's get started. Our legislature makes many decisions about the numerous state and federally funded programs that impact the health of kids and families. Health touches everything, and it is much more than insurance coverage and medical appointments. It's about people and the spaces and places where kids spend their time growing, learning, and playing. And it's about setting up kids and families to have the chance to choose to make healthy decisions. But even with modern improvements in our health systems, we are still far behind in the progress that moms and babies deserve. Before a mom even becomes pregnant, her health impacts her future child. Chronic health conditions need to be addressed and managed before pregnancy occurs to set up the best possible success for both mom and baby. We must do more to make sure each mom has access to affordable health care and can meet her needs before, during, and after pregnancy. When a mom isn't receiving the care she needs or is listened to, close calls with her own life, negative impacts on the baby like low birth weight, and even maternal and infant death can occur. But we can reduce low birth weight and other issues by making sure moms receive regular prenatal care, as regular monitoring can catch health issues early so they can be watched and addressed. Infants who do not receive prenatal care are 3 times more likely to have a low birth weight and 5 times more likely to die than those born to mothers who receive timely prenatal care. But as you can see on this map, there are parts of our state where the rates of prenatal care are much lower. Those are the blue colors. And that should concern all of us. No matter where a mom lives in our state, she should be able to access adequate medical care for both her health and the health of her baby. We need to do much more to investigate and solve the challenges around maternal health care in our state. Today, health insurance coverage is the most likely pathway to affordably access the healthcare system. When adults have access to and utilize affordable health care, they better manage their physical and mental health conditions, pursuing regular preventative care and treatments as needed. When parents are taking care of their overall health, they are able to work, pay bills, and afford housing, food, and other necessities, all of which lead to healthier outcomes for their kids. But when money gets tight due to cut hours at a job or a lost job, out-of-pocket healthcare expenses usually fall off the priority list when pitted against a rent payment or a grocery bill. So what access to affordable health insurance coverage do low-income adults have? Our next speaker after me, Ann Dwyer, from the Georgetown Center for Children and Families, will provide a broad overview of Medicaid and CHIP. In Kansas, this is known collectively as CanCare. What you need to know right now is that parents with kids already can qualify for the Medicaid program, but the current income eligibility level in Kansas is so low for these parents that a parent working a low-wage full-time job makes too much to qualify for Medicaid, and most likely makes too little income to qualify for federal insurance subsidies. Currently, a family of four's household income must be less than $11,856 to qualify for Medicaid. That's 38% of the federal poverty level. Those adults without kids can't qualify for Medicaid at all. To qualify for insurance subsidies on the federal exchange, which can result in as low as $0 monthly premiums, these families' household income must be at least $31,200. The gap between $11,856 and $31,200 is called the coverage gap. You see that visually represented on the screen. These parents in the coverage gap lack access to affordable health care options, delaying preventative care and only seeking care in emergencies. One potential solution available to cover these parents in the coverage gap is to expand Medicaid. But if our state won't pursue that, what solutions do you have to help these parents, which helps their kids too? The coverage gap continues for these parents, and delayed medical care results in much higher health costs for us all. Kids have access to health insurance in several ways, including through their parents' jobs, the Federal Insurance Marketplace Exchange, or through a state's public insurance program, like CanCare. Like I said, the next speaker will be diving much further into Medicaid and CHIP. Now let's turn to looking at two ways to change the trajectory of kids' lives. More than a century ago, kids regularly died from rapidly spreading infectious disease that we have not seen in most of our lifetimes, including polio, measles, and whooping cough. Kids and pregnant women are particularly vulnerable to these infectious diseases, which have harmful, even permanently disabling and deadly side effects. Thanks to scientists and medical professionals, most of these diseases are only a memory of the distant past in the United States, even as they are still present in other parts of our world and are only a plane ride away. Kansas has had childhood vaccination requirement laws for school attendance, first established in 1961, and childcare established in 1992, as well as for disease reporting and investigation and more. Vaccine exemptions are already available for medical and religious reasons in existing law. Unfortunately, we continue to see childhood vaccination rates decline, and infectious diseases like measles and whooping cough are on the rise again. It is crucial to continue to keep current policy in place because these infectious disease outbreaks will keep parents away from their jobs for long periods of time and cost society billions, even trillions of dollars. You can see on the slide how much childhood immunizations have saved society just over the last 30 years. Recently, there have been several attempts to relax or eliminate existing policy that prevent the spread of infectious disease. Kids and society benefit by keeping proven public health policy in place. And I encourage you to continue these laws to protect all Kansas kids with the decisions you make. For many kids, early diagnosis and interventions may resolve issues discovered early on, or at least stabilize them. For example, an infant experiencing muscle weakness and not meeting expected timelines for crawling and walking is referred by a pediatrician. After several appointments, the issue is resolved with physical therapy. And you would never know looking at that teenager today. Or a newborn screening panel results in a newborn starting treatment for cystic fibrosis long before complications begin. Early diagnosis and treatment now can greatly delay or prevent serious lifelong health issues. That is why kids, especially our youngest ones, should regularly attend so many doctor's appointments for well child visits, to regularly review development, and then work on follow-up diagnosis, treatment, and therapy as needed. Finally, numerous life situations, places, spaces, and systems directly influence kids' health. You may hear these referred to as social drivers of health or non-medical factors. Think about your own life. Where did you sleep last night? Did you have heat and clean air? Did you have access to breakfast? Did you drive a dependable car here? Some families don't have regular access to these items, which creates barriers to accessing medical appointments and jobs and causes chronic stress and anxiety, leading to additional health challenges. Housing conditions, including air quality, temperature, clean carpets, and no lead paint, as well as access to healthy, nutritious food, directly impact kids' health. And availability of time off of work to attend medical appointments can also significantly impact parents and new moms. So as you continue discussions during this session in future years, we do encourage you to pursue policies that remove barriers to healthcare in our state, such as removing CanCare enrollment red tape, increasing CanCare provider reimbursement rates, and addressing the gaps in maternal care. Second, invest in the programs that provide intervention and supports to kids and families, including addressing funding challenges for both the newborn screening program and special education programs in our schools. And third, support longstanding and proven public health policy that protect all Kansas children. My colleagues and I at Kansas Action for Children are always ready to be a resource for any questions you may have, especially when it comes to improving the health of all Kansas kids and their families. Thank you, and I'll stand for questions at the appropriate time.
Very good. Thank you, Heather. Committee questions? Representative Steens.
Hi, Becky. Thank you so much. Mr. Chair, thank you. I have a quick question. When you have that coverage gap up, just so I understand that, on slide, I think it's 8.
Sure. Thank you.
So that poverty level, the federal poverty level, that 38 to 100%. So I guess I'm a little confused. So you're saying they can meet Medicaid if they're under the 11,856 total, correct?
Yes.
But then they can't get I'm assuming, is that like the ACA they're not eligible for? Is that correct?
Yeah.
Okay, and why is that?
Mr. Chair, Representative Steens, I am not an expert on the ACA, but what I know is that if your income is between what your state's Medicaid eligibility rate is, so for parents, and only parents of children can qualify for Medicaid at this very low income level of 38% and below. When you are between 38% and then 100% of the federal poverty level, you cannot qualify for those federal subsidies on the federal exchange until you hit 100% federal poverty level for your household income.
Okay. Thank you. I'm just trying to figure out that formula.
Yep.
Very good. Committee questions? Seeing none, thank you, Heather.
Thank you.
Next, we have Ann Dwyer, Associate Research Professor. Is she WebEx? Yep. Is she on?
Hi, all. I'm on. I'm going to share my screen and make sure that the committee can see my slides.
And thank you for being here.
Great. And can everyone see the slides just to make sure?
Yes, we can.
Yes. Okay, great. So thank you to the committee for having me here today. As Heather mentioned, I'm Ann Dwyer. I'm an associate research professor at the Georgetown Center for Children and Families at the McCourt School of Public Policy. CCF is a nonpartisan policy and research center with a mission to support access to high quality, comprehensive, and affordable health coverage for America's children and families. So in particular, CCF conducts research, analyzes data, and examines policy development and implementation efforts related to Medicaid and the Children's Health Insurance Program, also known as CHIP, or in Kansas, known as CanCare. We also work with a number of state-based policy organizations across the country focused on advancing child and family health coverage, including Kansas Action for Children as part of our Finish Line network. So why don't I jump in? I'm going to give a little bit of an overview of Medicaid and CHIP and the financing, and then talk about some recent reports and data that we've put out related to rural areas. So just as a quick overview, Medicaid, or again as CanCare as it's referred to in Kansas, alongside its much smaller but important sister program CHIP, covers about half of all children across the country, including over 30% of children in Kansas. Medicaid also pays for over 30% of births in Kansas. And I know we're focusing on children for today's briefing, but I did want to also note that Medicaid is a major payer of behavioral health services and long-term services and supports. And along with covering children, pregnant people, and low-income parents, Medicaid provides health coverage to 4 in 7 nursing home residents in Kansas. 1 in 7 Medicare beneficiaries in Kansas also rely on Medicaid, and it provides coverage to 1 in 4 individuals with disabilities in the state. So as you may be aware, Medicaid is a joint state-federal program, so it's largely administered by the states within federal rules and guidelines, and then with the federal government picking up the majority of spending. So in Kansas, the federal medical assistance percentage, so that's the matching rate from the federal government, is a little over 60%, meaning that on average, for every dollar that Kansas spends on CanCare, the federal government picks up over 60 cents on that dollar. Medicaid is also the largest source of federal funding to states across the nation, including in Kansas, where it is the single largest source of federal funds into the state. And when it comes to children's coverage, Medicaid alongside CHIP has helped make huge strides in lowering the rate of uninsurance for children across the country. So as we see in 1997, before the passage of CHIP, uninsurance for children was around 14%. Then CHIP was enacted. We then saw after that, after enactment of the ACA, which included a number of policies to improve access to coverage for children, along with welcome mat effects that uninsurance rates went down even further. Uninsurance hit an all-time low for children during the period of continuous coverage protections that were in place during the COVID-19 public health emergency. During the unwinding these continuous coverage protections afterwards, we did see some coverage loss once those continuous coverage protections were lifted. So we still have some work to do, but as we can see overall since 1997, the country has made a lot of progress in covering children and making sure they have access to health coverage and healthcare services. And according to our latest data, Kansas's current uninsured rate for children is about 5.6%. And for this slide, I'm not going to get into all of the specifics today, but I did want to mention a really important component of Medicaid for children, and that is what is known as Medicaid's Early Periodic Screening, Diagnostic, and Treatment Protection, or EPSDT benefit. And the key thing here is that when it comes to Medicaid, if a service is medically necessary and can correct or ameliorate a health condition and could be covered by Medicaid, then Medicaid is required to cover it. So it really makes those optional services mandatory for just children. This is different than for adults. And this is a really important protection that is specific to children and ensures they have coverage for the things that they need to stay healthy. And we do have some work to do here to make sure that the reality of this promise for EPSDT, the reality on the ground is living up to this promise and this protection, but it really is a key component of the Medicaid program, so I did want to just make note of it. And when it comes to outcomes, we know access to Medicaid coverage in childhood addresses health outcomes by providing access to affordable, quality health coverage, but also has important long-term beneficial educational and economic impacts. So for example, Medicaid coverage for children and their mothers during pregnancy is associated with increased rates of high school graduation, on-time high school graduation, college enrollment, and four-year college graduation. Medicaid coverage for children and pregnant women also produces considerable financial benefits for both individuals and society at large. It raises both children's earnings in adulthood and improves intergenerational mobility, which in turn increases tax payments that help offset the earlier investment in health coverage. And what's really important to note is that these positive impacts on Medicaid coverage are multi-generational. For example, a study in the American Economic Review found that children born to women who benefited from Medicaid pregnancy expansions coverage eligibility were more likely to have children with better birth outcomes. So that's a two-generational. So their grandchildren have better birth outcomes. So finally, I wanted to touch on a new report from CCF highlighting the critical role Medicaid and CHIP play for small towns and rural communities. As noted in our report, non-elderly adults and children in small towns and rural areas are more likely than those living in metro areas to rely on Medicaid and CHIP for their health insurance. And this is also true in Kansas, where more children in rural areas and small towns rely on Medicaid and CHIP than in urban areas. And while nationwide, about 14% of people live in small town and rural areas, that is closer to 30% in Kansas. And finally, this is why federal threats to Medicaid funding that are being contemplated in DC could have a significant impact on rural communities. As I mentioned earlier, Medicaid is the single largest source of federal funding in Kansas. Significant cuts to federal Medicaid funding would simply be a large cost shift to the states. Given the magnitude of cuts that are currently being contemplated nationally, states would be left with very few choices, essentially raising taxes, severely cutting other parts of their state budgets, and or making deep, damaging cuts to their Medicaid programs. And in Kansas, this largely means children, pregnant people, individuals with disabilities, and seniors. So with that, I will note we provide regular updates on the latest happenings on the CCF website and our SAA blog. We also have a state data hub on our website where you can find more information on coverage trends, policy options, and quality metrics for Kansas and CanCare. So again, we have a state data hub with a bunch of Kansas-specific information if you're interested. So with that, thank you again for the opportunity to present to the committee today, and I am happy to answer any questions.
Very good. Thank you, Ann. Committee questions? Seeing none, we do not have any committee questions for you. Thank you for being here.
Thank you.
Okay, next we have Mariah. Mariah, welcome to committee.
Hi, thank you. Mariah Crayons with Community Health Council of Wyandotte County. We serve families in the entire metropolitan area in Kansas City. So I'm going to talk to you a little bit about wraparound services and how those benefit families in coordinating health as soon as I can figure out how to do these slides. All right, so Community Health Council of Wyandotte County has been around for about 22 years. We focus on advocacy, collaboration, and convening organizations and community members together to improve the community in Wyandotte County. We went beyond that in about 2015 with a community health worker program, and that has since expanded to both sides of the state line and included maternal community health workers. We also have a health insurance enrollment program as well. So one important piece to note about community-based services is that they have a little over $2.70 ROI for every dollar spent. So when you are investing in community-based services like community health workers, home visiting programs, parents as teachers, those types of things, you are getting almost a 3-to-1 value for your dollar. They're not moving. There we go. So some of the things that community health workers address are your social drivers of health, like Heather had mentioned. This includes the complicated web of helping families access any type of service that they may have a challenge accessing, like food, transportation, even things such as getting your child enrolled in school, finding health care, getting food benefits, enrollment in health insurance programs, and in other supporter programs in the community like SNAP, like daycare assistance, and TANF as well. You see this is a very complicated spaghetti-looking map, and that's intentional because that's what it's like. If you have one positive social driver, meaning that you have a trouble with transportation, and that may mean that there's a bus stop by you, but that bus may not run after 8 p.m. when you get off of work. Or it may be a mile to walk to that bus stop with your children who are sick, who need to go to the doctors, and you work an hourly job, and now you are out your daily wage. That then helps to pay for rent and food. Community health workers help to navigate that whole process with you and reduce those barriers and make this web look more like a straight line. Did it go? Sorry, I'm moving faster than the slides are. I wanted to include this diagram for you, which you should have it in your printed packet. This is what the referral process looks like for a community health worker or a navigator or a case manager, and this is for one topic referral that they have. The process is complicated, convoluted, and long, and families are usually engaged in this process for at least 3 to 4 weeks. One important thing to note is those lines on the bottom. It's a constant continuum back and forth of helping those families access those services. Sometimes it is helping a family by making a phone call for them. Sometimes it's helping a family by sitting with them while they make the phone call. The ultimate goal of a community health worker, case manager, navigator is to help families and individuals be able to do these things on their own. But in the beginning, in a moment of crisis or a moment of stress, they may not be able to do that themselves. I'm going to guess that for most people, especially people sitting in this room today, it is very difficult for us to identify where we need to go for help if there was an emergent issue, like, for example, we no longer had access to food. Do you know where to go to access food? Do you know that most places to go to access food, you have to show ID and proof of income? Proof of need, basically, that you are hungry and need food. That's a big problem. Community health workers and wraparound services can help to reduce that barrier for all families, improving total family health. So how can you help to improve family-based services? There's a couple things that we can do collectively. Some of them include things like making sure that non-clinical support services are available and accessible to everybody with no barrier. So no income barrier and no barrier for zip code or place of residency. A lot of times programs that provide these types of services, you only have to, live in specific zip codes, or they're only offered to a very small subset of people. In reality, that shouldn't be the case because just about everybody can benefit from wraparound services. An example of that is I have a child with chronic disease and rare disease. She's now 20, still in the hospital. She's been there all month for January, and we're still there today. I begged for wraparound services for her for years, from providers, from hospitals, from caseworkers, from our insurance caseworkers, zero. We got zero support and help for a child who has 17 different specialists but didn't qualify for disability in this state. Wraparound services is critical for families in a non-clinical setting. I cannot express to you the amount of challenges that we faced getting her the care that she needed that eventually has resulted on us going out of the state for care for her because we can't get it here. So that's important to note for all families, not just those with complex needs. It is incredibly difficult to get those services, so supporting non-clinical avenues is really important. Additionally, invest in those community-based programs. Community-based programs are often last to receive funding when it comes to supporting families. So community-based programs can be supported through grants, through contracts, but also through sustainable and reliable reimbursement methods, which brings me to reducing barriers for those reimbursement methods. The state SPA for community health workers is complicated, convoluted, and not accessible to the majority of employers that employ community health workers. So ensuring that things are accessible for families or accessible for the organizations who provide the support, and we're looking at longer than 1 year support, which is the standard right now. We need to be funding these programs long-term with long-term investments in our communities because the people who are running these programs and the people who are doing this work are from the very community they serve. So you are really investing in that community. And I'll take questions if you have any.
Very good. Thank you. Thank you for that. Committee questions. Representative McDonald.
Thank you, Mr. Chair. I'm just curious about the ways people get referred to the helpers in the world like you.
Yeah.
I could imagine, our state is largely rural, but there are a lot of people in those population centers. So what does it look like for a rural resident to try to get help like you provide versus in an urban setting or a suburban setting?
It's a little bit different across the state. The communities that have community health workers in your rural and frontier areas in Kansas, they mostly have community health workers who work out of insurance companies and they're phone-based. There are some that are based in health departments or federally qualified health centers, but it's important to note that when you have phone-based care, you are not developing the trust and the relationship that is needed, and those are often limited by time. So typically, most community health worker programs in the state are limited by 60 to 90 days enrollment, and that's all you get. That is not enough time. It is not enough time to even get an approval back for most programs. So it's really important that those open-ended timeframes are available. Some referrals come from the insurance companies themselves, where they'll refer to a program they know exists in a community. Sometimes it comes from a hospital, sometimes it comes from a school. But there are several bidirectional referral networks that are used in the state, Unitas and Iris being two of them. Aunt Bertha is another one. Those are often used for community health worker services and community-based supports to get referrals for families. But then again, you also have to remember a lot of programs have eligibility requirements. There are very few that do not have an eligibility requirement.
Representative Reeves.
Thank you for the presentation. Can the community health workers, can they bill Medicaid?
So
I don't know if there's a
yes
code
and
for
no.
that.
The state plan amendment that was passed several years ago for community health worker support and reimbursement does allow for billing if you work at a federally qualified health center that has, and I don't know the exact term, it's a complicated acronym, but my understanding is if you can bill for individual lab services as an FQHC, then you can bill for community health worker services. Entities that cannot bill for community health worker services include community-based organizations and hospitals. And the reimbursement rate is very low. Even with the increase, it's still low.
Committee, further questions? I do have one. You mentioned one that I was actually going to bring up. So Unite Us.
Mm-hmm.
So, you know, that's a new pilot program that we've been working on. So how would you rate that if you were rating that program?
The program itself or
Well,
the
you know,
accessibility?
Yeah, just the ancillary, how it gets you in contact. You know, the whole design of it's to put people in contact with resources.
The platform itself is very good. It's very user-friendly. It's pretty intuitive, and it's accessible, and it does allow for really good communication back and forth between the entities and the individuals that are referring within those entities. A couple of the benefits of using a program such as Unite Us is that it does have if you will, a lockdown effect. So you can't just go on as a user and search someone's name and see what they've been referred to. It can lock down an account. So if there's a case of abuse, if there's a case of violence, if there's any type of protected information, you cannot access that referral unless it's been sent to you directly, unlike Iris, which you can. Iris is an open database. It's wonderful for the purpose it was built, but it does have some challenges with it. As a user of Unite Us, I can tell you there are not enough organizations in it yet in the Kansas City area to make it really fully effective for us. And one of those challenges is that their rollout, my understanding statewide, has been with DCF and not with all of the other entities. And the other challenge with it is that the referral networks don't talk to each other. There are actually 10 different referral networks that are used in the Kansas City area. And some of them are required by state grants to be on, like we're required to be on too. But they don't talk to each other. So we have to log on to 2 different systems, and not everybody's in both systems. And then in addition, there's all the other systems that part of our partners are in. And so our team may spend 25 minutes trying to find this right system that has the right partner in it that we can refer to for a client. So sometimes we just pick up the phone because it's easier. Unitas has the option to do that. It has the opportunity to do that. They have agreed and decided they want to be an API connector with the other case management systems and the other referral networks in the region. However, the other referral networks are not always willing to come to the table to do that. So there's duplicative effort on the other end of the workers.
Thank you for that. So what would you think the largest barrier to folks using Unite Us would be for providers?
Interconnectivity with other programs. There has to be interoperability between all the different referral networks and different providers in EHR and case management systems. It is incredibly duplicative to have to document in your case management or EHR system, go into your referral network and document, send the referral, go back and forth with communication, then go back to your case management or your system of record to document again. That's 3 different times. You're talking almost 45 minutes of documentation alone, which takes away from the time that you spend with families. In addition to that, with Medicaid, that is time you cannot bill for. With Medicare, you can. Medicaid, you cannot. So there's no reimbursement effort there.
So in the providers that you mentioned, why do they not sign up for Unite Us?
because they have to use other ones, or they're already using another platform.
They have another platform.
Yeah, and the other platform may integrate with Epic or with ECW or with another case management system or another EHR. So when we have all these different platforms that all these different providers and entities are using, if they do not talk to each other, they have the ability, but if they don't do it and there's no incentive to do it, you're never going to solve this problem.
Yeah, thank you for those words.
It's a frustration we all feel.
All right, committee, further questions? Thank you very much for being here.
Thank you.
Next, we have Christy. I'm not even going to try to attempt. Christy, welcome to committee. Thank you.
Shun. Good afternoon, Mr. Chairman and
Say that, could you say
shun.
shun? Okay. I would have butchered it.
Creation. I can shun you, that kind of thing. I'm just going to play with my clicker here a minute. So good afternoon. Thank you for having me this afternoon. Like you know, my name is Christy Shun. I'm a social worker. I serve as the executive director of the Kansas Infant Death and SIDS Network. We are a statewide nonprofit organization dedicated to supporting families affected by miscarriage, stillbirth, and infant loss, while also working on reducing preventable deaths through education, professional training, and community outreach. The Kids Network was first formed and founded by Ted and Susan Bradyhoff in 1998 after the death of their granddaughter, Haley Elizabeth Slaymaker, and she died in those days of SIDS. Today, we would say sudden unexpected infant death. And as a clinical social worker, I have been serving the network since 2000, specifically focused on providing grief support to those families that have had the untimely death of their child, and trying to eradicate stillbirth and infant loss. I've met and served over 900 families, and I hope that we've saved many, many more babies. Thank you. Let me begin by talking about what stillbirth means. Stillbirth is the loss of a baby before or during delivery, occurring at or after 20 weeks of pregnancy due to natural causes, such as complications with the placenta, infections, and genetic conditions. Despite advancements in our prenatal care, the Kansas stillbirth rate has unfortunately increased from 5.6 per 1,000 total deliveries in 2021 to 5.9 per 1,000 in 2022. This concerning trend underscores the need for continued research, awareness, and interventions to prevent these heartbreaking losses. Infant mortality, on the other hand, refers to the death of a baby before their first birthday. In 2022, Kansas saw an increase in its infant mortality rate to 5.8 per 1,000 live births. The leading causes include congenital anomalies, sudden unexpected infant death, or what we call SUID, and complications related to preterm and low birth weight. According to Kansas Action for Children Kids Count, Kansas remains slightly above the national rate of 5.6 per 1,000 live births, but we are below our neighboring states of Arkansas, Missouri, and Oklahoma. SUID, just a little more definition here, is an umbrella classification that includes any unexpected death in infancy before 1 year of age. And SUID consists of, and I'm going to kind of be a little bit nerdy here for a second, but these are some of the deaths that we're seeing in Kansas and across the nation. One is called accidental suffocation or asphyxiation in bed, or ASSB. This is a death in the sleep environment with a confirmed cause of the infant's nose and mouth being covered or the neck and chest being compressed from soft or loose bedding, overlay like another person, or wedging like between a mattress and a wall. There is also SIDS, which we've all, I think, heard of, sudden infant death syndrome, and that is the death in a sleep environment that cannot be explained after a thorough case investigation, including death scene investigation, autopsy, and a review of the clinical history. SUIDs might also be categorized as as external factors such as infection, poisoning, and medical disease. And then finally, there is the categorization of unknown, which is when there's not enough evidence to make a clear diagnosis. And sometimes they get labeled as undetermined causes of death. And we really hate to see that because it's hard to help people understand what to do different if we don't know or don't say what it is that caused that infant's death. And in many of those unknown causes, there are unsafe sleep factors that are present. Sleep-related SUID deaths outnumber all other causes, occurring 10 times more than drowning, twice as often as homicides, and even exceeding motor vehicle fatalities, one of the leading causes of death in our age groups. Despite this, SUID rarely receives the same public attention. While media frequently highlights the other risks, there is very little awareness about the dangers of unsafe sleep. The data underscores the urgent need to prioritize safe sleep education and prevention efforts. By raising awareness and implementing evidence-based practices, we can reduce these preventable deaths and protect our most vulnerable infants. So as you likely know, the State Child Death Review Board analyzes trends and risk factors in child deaths from birth through age 17. In their most recent report, they state that sleep-related deaths remain a major factor, with 45 such cases reported in 2022 alone. Data from 2018 through 2022 highlight some of the key risk factors, such as 99% of the sleep-related infant deaths involved at least one unsafe sleep practice, such as tummy sleeping or a blanket or a pillow or co-bedding. While 54% of the cases involved infants sharing a sleep surface with another person, so that baby being in bed with generally a parent or a caregiver, sometimes with other children. And 52% of infants were placed in unsafe sleep positions, such as on their stomach or their side. Again, these findings highlight the urgent need for safe sleep education and prevention efforts. As we work to decrease stillbirth and infant mortality, it's important to look at who's affected most. In Kansas, Black women face a 2.2 times higher risk of stillbirth compared to Caucasian women. This disparity persists even among non-Hispanic Black women who receive adequate prenatal care, largely due to higher rates of conditions such as diabetes, high blood pressure, or placental issues. The underlying causes of this disparity are complex, and they are continuing to be studied. Additionally, while higher education is associated with a lower risk of stillbirth, the protective effect is greater for Caucasian women than for Black and Hispanic women, highlighting the need to prioritize interventions to address these inequities. Although the overall infant mortality rate is declining, significant racial and ethnic disparities also persist among the SUID deaths. For instance, Hispanic infant mortality rose by nearly 5 points between 2021 and 2022, while Black infant mortality showed a 3-point improvement during the same period. Overall, from this graph, you can see that the deaths for people of color continually remain higher than those who are Caucasian. Infant mortality is not, unfortunately, always preventable, but policy reform and investment in maternal care can help mitigate these infant deaths. Increased prenatal and postpartum care access, mental health care, newborn screening, universal home visitation, paid family leave are all policies that can reduce infant mortality. This gives parents and their caregivers the necessary tools to help their kids survive and thrive. The Kids Network infuses safe sleep and stillbirth reduction strategies within existing programs to provide more robust education to new and expected parents. One such example is what we call the Kids Network Safe Sleep Instructor Certification Project. You'll see a lot of words up here about what that project is. But basically, instructors attend a 2-day training designated to build the skills necessary to implement established, evidence-supported safe sleep programs, such as the American Academy of Pediatrics Safe Sleep Recommendations. This train-the-trainer model provides the foundation for sustainability and expansion of the safe sleep campaigns that are nationwide and creates the vehicle for delivery of what we call at the Kids Network a safe sleep community baby shower. So what is this Safe Sleep Community Baby Shower? I hope some of you are familiar with it. We have gotten them in about 42 or 43 counties across the state of Kansas thus far. But thanks to a partnership with the Wichita Black Nurse Association, the Kids Network, and multiple collaborators, and I'll emphasize multiple here, the list is so long at this point, especially since we are across the state and in a couple of other states. Each community has different collaborators that come to the table. So we're really trying to wrap our hands around all of the people that are taking care of mothers and babies in these environments. It's called this Community Baby Shower. We align diverse multi-sector interventions to increase knowledge and intention of caregivers to sleep their babies in safe environments and provide a gateway to maternal child health services that reduce infant deaths and stillbirth. These events create a point of entry so that new and expecting families can come together to positively and equitably impact their families. This in turn reduces not only stillbirth and infant death, but it reduces extended hospital stays and further need for special education needs. But it also improves the family's ability to live, to work, to learn, to pray, and play in their communities. What we know is that healthy moms make healthy babies. And what we know is that healthy families create healthy kids and healthy communities. And so I thank you for your time and attention today to this critical issue. I'm here on behalf of our board of directors and the 900+ families that have unfortunately found their infants unresponsive, often in a bed next to them or in their crib. And it's those people who have asked us to come forward and say, please continue to help reduce this rate even more. And with that, I'll stand for questions.
Very good. Thank you, Christy, for that. Committee questions. Representative Steins.
Thank you, Mr. Chair. Thank you, Chris, for your presentation. I had a question, and that may have been in the slide, and I didn't see it. Since they have been educating mothers on having the baby sleep on their backs in that supine position, do you know what the numbers were like before previous? Because that started, what, about maybe
92.
Was that 92?
It was
Okay,
92.
wow.
1992 is when the American Academy of Pediatrics came out and said, put your baby on its back or its side. And then in 96, they came out and said back only. And so we've been doing back only since then. One of the slides showed is that when we look at, so the Child Death Review Board, when they're looking at the child death, and I might need to go back here, sorry, I know you. Let me just look here. We're going to the beach. Actually, could be a little warmer. I appreciated yesterday. So let me look here. 52% were placed on their stomach, side, or a position other than the recommended supine back position. So that's of the babies who died. So of the 35,000 that are born every year in the state of Kansas, I have a hunch that a lot of them are doing back to sleep, but I can't say that for sure. With the data, we have data on the babies that died and how they were placed. And over half of them were placed in a position other than what the American Academy of Pediatrics recommends. We have much work to do. I feel like we've all known that. 1992. I graduated from college that year. That was a long time ago.
It's been a long time. That's why I was wondering.
Yeah, and so what we know and we say a lot is that that safe sleep is as easy as the ABCs, alone, back, crib. But we all know that changing our behavior is harder than the ABCs, such as Did everybody walk 50 minutes today? Did everybody take their vitamins and drink as much water? So changing behavior is harder than changing the knowledge. We think they have the knowledge.
Can I ask a really quick follow-up question? Sorry, Mr. Chair.
Very quick.
Really quickly, do you think, I know this sounds kind of weird, but do you think there's a stigma with the flat heads and the kids needing the helmets? I'm really truly asking that because I have heard parents say that. Thank you.
I think it has been an issue in the past. I don't hear that as much recently as I did before because the flathead is not as prominent today as it was back in the, maybe 2005, 6, 7. So I think we've alleviated some of that concern, but I'm sure there's still families out there and that's part of our education is you need to have the kid on their backs to sleep, but you need to be holding them and engaging with them during the day, not only to develop relationship, but also to round out the back of the head. So,
Very good, Christy. Thank you very much for being here.
thank you.
Next, we have Dina Hubbard. Dina is virtual. Dina, are you there?
Yes.
We have about 10 minutes.
Okay. I'm trying to share my slides. Can you see my PowerPoint slides?
Not yet. He can put them up from here.
That would be wonderful.
Very good.
All right. So while you do that, thank you.
There they are.
Thank you. I can see that. Thank you so much. My name is Dr. Dina Hubbard. I am a pediatrician and a neonatologist. I take care of sick and premature babies in the neonatal intensive care unit. I'm here today on behalf of the Kansas chapter of the American Academy of Pediatrics. Next slide, please. I am the public policy chair. I'm sure I've been in front of this group before. Thank you, Mr. Chair of the committee, for the opportunity to be here. The Kansas chapter of the American Academy of Pediatrics helps pediatricians care for kids. And this represents over 400 pediatricians in our state. And our goal is really to promote the health and well-being of Kansas children and their families through education, opportunities like this, advocacy, networking, many programs and services that we provide. You may be familiar with the CARE program, the Child Abuse Review and Evaluation Network that we worked with the legislature on, the Turn a Page, Touch a Mind early literacy program. We have Pediatrician in Action Award programs focusing on priority needs and quality improvement initiatives such as immunizations. But we are a leading voice for children and pediatricians in Kansas. Next slide, please. So as you've heard today, we all know that prevention is a much better investment than treating disease. And so we know that early medical care leads to better long-term outcomes. And this is very evident in children. And I will be talking a little bit about trauma-informed care, which reinforces this notion. So making sure that children have access to preventative care before problems develop, or to recognize early on when a problem is developing, is more likely to set them up for success, for healthy development and learning, and less likely chronic diseases later in life. So this includes the well child visits, as has been mentioned, many of those in that first year of life, screenings, developmental screenings, and vaccinations. Again, we can't prevent all harm from our children, but the things that we can, we certainly want to optimize. We know that there are disparities, as has been pointed out, in certain areas of our state. Coming from a small town of 800 myself, I'm very well aware of that. So making sure that we meet those needs. And again, this is for a long-term impact. This is not something that you're going to see within a short term, but it's a great investment. Next slide, please. So you've heard about this, that Medicaid is really important for children. So I would really like to emphasize that point again, that Medicaid is primarily a children's program. I think in the public, it's often thought of as a poor adult program, but it is primarily a children's program. And so in Kansas, 68% of Medicaid enrollees are children. So this is very, very important for our kids. Again, it's a great return on investment, because if we can identify issues earlier, these are going to be more productive and healthy citizens in Kansas later on. Next slide, please. You've heard a little bit about coverage gaps in terms of the exchange and then above Medicaid. Another gap is when children lose Medicaid coverage, and which we have seen with the unwinding. Many kids were affected by that. And then that's a critical time in which they may not, if they don't have access to care, there may be things that are missed, which are then much more problematic to deal with later, more expensive, leads to more expensive ER visits, and that's outside the relationship of the medical home with their pediatrician. So we want to always advocate for anything that decreases that red tape that I know we all are challenged with, so that especially those early, very formative years where we can make the most impact by intervening in those first 5 years of life, having the continuous enrollment really helps with that. As has been mentioned, and I see this as a neonatologist, the most important time for a mom to be healthy is before conception even. So Medicaid expansion and things to make sure that families are healthy is going to affect the well-being of their children. And it has been mentioned, the low Medicaid reimbursement rates. I'd like to put in a plug that kids are not little adults. They actually have very unique specific needs that pediatricians and other healthcare providers are trained to identify and help them. And so it's just because they're smaller, their payment shouldn't be smaller. There's a lot of work and investment in them. Next slide, please. So now I want to transition a little bit to trauma-informed care, and I think I've had the opportunity a few years ago to talk to this group about what trauma-informed care is, but it's something I just want to briefly mention. It's very important, and it's been really career-changing for me as I learned more about trauma-informed care. We do know that all children, all of us have experienced stressful events in our lives. There's nothing that can take that away. However, what sets it apart from whether a stressful event, a very severe, intense, or continued trauma, whether that leads to post-traumatic stress disorder or PTSD, or post-traumatic growth, is there a buffer? Or is there a context, a relationship for that child to where they can recover from that stress? And so that balance between stress and then the supportive buffers is really important. And you've probably heard of the fight or flight response. That is a biologic response that helps us in times of danger. Now, the problem is our brains don't always know the difference between a saber-toothed tiger, which we don't have to worry about too much in Kansas, or other kinds of trauma. So I wanted to show this visual to you. And if you don't mind, if you think of your hand as the brain, and so if I invite you, if you're comfortable, to hold up your brain, and we'll do this exercise together quickly. But your palm and your wrist here is the brain stem. This is the automatic part of your brain. You don't have to think about your heart rate, your respiratory rate. It's just taking care of those things. Then your thumb. This is your emotional brain. This is where, when you're in kind of fight or flight, this is what comes into play. And then your fingers, this is your prefrontal cortex. This is your thinking, rational brain. Okay, so think about if there's a big stress or a toxic stress, you don't want to engage this thinking brain, right? You just need to act. Okay, so this is your amygdala, that again, that's kind of very primitive part of your brain. And so think about if your thumb is moving around because you've got a tiger running after you, you're going to flip your lid. And I know I have flipped my lid, and I'm sure most of you have as well at some time. But that's when you need that survival instinct to kick in. So, but then the important balance part of that is, are there supportive relationships and things to bring that, engage that prefrontal rational thinking brain? Now think about if that, if you're always under fight or flight, that thumb is just moving around. If your lid is always flipped, you can't learn in this instance. You're in survival mode. Your brain can't grow well when you're in survival mode. And so that's really where trauma-informed care comes into place. If that stress is never turned off, there are long-term consequences. And what we've learned about is that early childhood adverse experiences, if that lid is always flipped and they're in survival mode all the time, then they are going to have chronic diseases. And we know that, so we don't think of that starting with children, but that really is that inflammation and that chronic stress starts in childhood. So if they don't have that buffer, their basic needs met, like food and housing, access to medical care, safe, stable relationships, they're more likely to have chronic diseases, to the point that those adverse childhood experiences can have more of an impact than your blood pressure or your cholesterol levels, your hemoglobin A1C. So that's very important, as well as much higher risk of suicide, mental health problems, and shorter lifespan. So if you're able to bring up the rest of my slides, I'll just finish briefly. I like that visual to think about, again, kind of flipping our lid, and how most of us have had a relationship and ways to kind of buffer that, bring that back down to normal. So it's a very powerful relationship between the child and their caregiver. Also, we have to recognize that many of their caregivers and parents may not have had safe, stable, nurturing environments. So we need to support those adults so that they can better support their children and kind of stop that cycle. Likewise, there is a relationship between the medical home for children and their children and families. This is a very sacred relationship that we do not take for granted. And it's through those relationships and over time that we can help, again, identify, something that's going on, intervene, especially in those first 3 years, where we can really impact and change the trajectory for their adult health. So in your slides, you'll see here about the high prevalence of trauma. Again, trauma is pervasive, but I wasn't sure if everyone knew about the relationship to adult health. So pediatricians, doctors, nurses, mental health professionals, and others that have provided information today are really key in identifying and addressing this early on. Next slide, please. So again, I hope I've, in this brief time, and I'm happy to provide more information, but trauma-informed care is really critical. And it provides a frame shift. Instead of thinking, what's wrong with this person? So when I see a mom that has used substances and she's delivering her baby and I need to evaluate her baby, instead of thinking, what's wrong with this person so that I can fix her or I can judge her, to change that thinking and what's happened to this person? What pain, what awful thing has happened to them? And so when I see a teen mom that's delivering and has had a suicidal attempt, my first thought is no longer what's wrong with this person. It's what has happened to this person. Something very awful has happened to this person that they're in this situation. And so then I can understand and be an ally for them. So again, pediatricians, other healthcare providers, and community resources are safety nets early on. Of course, all of you have the expertise that I do not, so a legislative impact on child health is very, very important, and again, a great return on investment. Next slide, please. Okay, next slide. Again, I want to leave you with relationships. So important, from the child and their primary caregiver, at least having one stable, nurturing adult caregiver for a child is invaluable. It's really, really important for kids. Likewise, that relationship between the pediatrician and the family, the parents and the child is very, very important. And that way they can work together along with their community to meet their most basic needs. Next slide, I believe is my last one. Oh, one more. I included some of those just for your reference. So supporting responsive relationships, reducing sources of stress, those adverse childhood experiences that I had mentioned, that includes poverty, racism, violence, food insecurity, housing insecurity, abuse, physical, sexual, emotional abuse, household dysfunction, including domestic violence, intimate partner violence, exposure to that, having a parent or caregiver with an untreated mental illness, substance use in the home, having someone in the home incarcerated. those are all extreme risk factors and really minimizes that ability to have that buffer. So we want to support the child within the context of their relationship. We want to reduce those sources of stress. So again, when you're talking about numbers and making the difficult decisions you have to, please remember that some of these very basic needs like food are so important, because if a child is so hungry and they're worried about where they're going to get their next meal and things are rough at home, their brain can't grow and develop and learn. Okay, next slide. I really do believe is. So I'll leave you with this. Again, advocating for early accessible support, team-based, culturally responsive care, addressing the root problems. From a quality improvement standpoint, we know you have to get to the root of the problem, and I would encourage you to try this shift in approach instead of what's happened, what's wrong with this person, to what's happened to this person. And I will remain for questions. Thank you so much for your time.
Very good. Thank you, Dina, for being here. Committee questions? Seeing none. Very good. Thank you.
Thank you.
Committee, I will tell you that the vacation is over. We're going to work next week, hearing bills and working bills. So just hang on, be prepared to work after hours, depending on what we end up working or hearing. So we've got a lot to do in a short amount of time. So with that, we're adjourned.